Going back to my travails through 40 plus years of practice, and these two articles are kind of out of order in the way I stumbled into them. This first paper was published in the fall of 95 in the old defunct ACAM journal, which was actually a pretty good journal, where we found a case which clearly was hibernation in peripheral arteries, which had not been described up to that point. Clearly what happened with this lady, the arteries were not plugged up or atherosclerotic, they were clearly hibernating. By way of explanation, so we're all on the same page, the terms hibernation and stunning are terms of art developed in clinical cardiology. Hibernation was first described after bypass surgery when areas of heart muscle that were thought to be dead and scarred began to work after circulation was reestablished by bypass. The same principle was then found to happen with angioplasty and chelation therapy. The underlying mechanism for hibernating tissue beginning to function again has still not been clearly enunciated, but it's thought that reestablishing circulation was part of the tissue beginning to function again. Stunning occurs after blood supply is resupplied to an area not functioning, and in that case, tissue gets the blood supply, but it doesn't start to work again for hours to days to several weeks. And again, the metabolic underlining of stunning has never been clearly explained, but in all probability involves function of the cell metabolism and the microcirculation after reestablishing macrocirculatory flow.
Hibernation and stunning treatment options. Tissue thought to be dead from a heart attack or a stroke may very well be stunned or hibernating, alive but not functioning. This tissue has the potential of coming back full function again when circulation is restored. Oxygen and nutrients need to get to the tissue, and waste products need to be eliminated. Non-invasive treatments, including EECP, enhanced external counterpulsation, EDTA chelation, biooxidative therapies, for example, multiple step oxygen, ozone therapy, hyperbaric oxygen therapy, can potentially assist in restoring function. Additionally, through the use of EECP, new pathways can be created for blood to flow to oxygen-deprived organs. For an example of how oxidative therapies and EECP can reverse stroke damage, go to icih.org/reverse stroke damage. Now, back to Dr. Edwards' lecture slides.
This lady was in her 50s. She had really no complaints other than some fatigue and no claudication, nothing. We ran vascular studies on her, and as you look at this, because Gene will go through this test with you, the segmental blood pressure show there's no evidence of plaquing in the arteries, but the pulse volume recordings show the arteries were stiff like pipes. There was no compliance. And we put her through chelation therapy, and her arteries normalized. You can see the difference.
For those of you unfamiliar with chelation, this slide shows the definition of chelation, and the next slide shows the mechanism of how it works. And now back to the slides.
Here's before, here's after. And this was not classical disease. What happened to this lady, she was born with coarctation of the aorta. She had coarc repaired in her 30s. We found her in the 50s and chelated her, and we revivified those arteries. And that kind of went into my unconscious with how could that possibly work? Although we had the documentation it worked, how could that actually work if you go back to the conventional thinking of atherosclerosis as cholesterol? This was her PPG, her post-photoplethysmograph, which is the test we do to measure it, sometimes called a post-occlusive reactive hyperemia. That's the result of the test. And this is the most accurate test in research now to pick up endothelial dysfunction, which is synonymous with small vessel disease. This was her test before we did the chelation, and this was her test after we did the chelation. So clearly, the pronounced part of this was the microcirculation. This is in her toes, because Gene will explain this later, clearly responded to what we did. Now, this paper, I actually stumbled into this first when I was working with Dr. Tang and Dr. Soli, they enticed me over to their offices by allowing me to use a high advanced nuclear scanner called the First Pass Baird Atomic 77 system, which was like giving an 18-year-old a Ferrari, because I was fooling around in the hospital at that time with nuclear cardiology before the field existed. And they said, well, here's this machine. You get to play with this machine. And after we published the stunning arteries in the legs, I went back and looked at this and realized the same thing was happening in the heart. And so we published this, but actually this case came into my field of vision before the peripheral arterial case. Now, this machine, it could detect very, very subtle motion, very, very subtle movements of isotopes much more accurately than a single lens Anger camera.